Hi, I'm Dr. Bhargava. In this short video, I'm going to be talking to you about I-131 therapy for Graves' disease, and I will share a case of solitary toxic nodule. Our first patient is a young female who presented with hyperthyroidism and initially underwent an ultrasound of the neck. These are the images from the ultrasound of the neck showing enlargement of both lobes of the thyroid with heterogeneous echogenicity, and the color Doppler images showing hyperemia in a symmetric fashion. The next step in this patient's management was I-123 uptake and scan, and here is a anterior image from that study showing increased uptake in both lobes of the thyroid and pyramidal lobe activity, suggesting Graves' disease. Her uptake value at 24 hours is very high at 68.3%, and so she is a good candidate for I-131 treatment. The question is, what dose of I-131 would you use to treat this patient? Do you use a fixed dose of I-131 or do you use a variable dose to treat different patients? A quick search of the literature showed me these articles where authors have used both fixed and variable doses, starting with the article published in 1975, where authors used an average dose of 13 millicuries and found a response rate of 90%. In 2001, in this article, authors compared the two fixed doses of 5 and 10 millicuries and found a response rate of 65 and 85% respectively. In 2002, authors used an 8 millicurie dose deposited in the gland based on the uptake value and had a response rate of 86%. In 2004, these authors in this article used a fixed dose of 7 millicuries and had a response rate of 75%. In 2005, some authors again compared the 5 and 10 millicurie doses and found a response rate of 48.5 and 88.5%. Several authors have identified factors that are involved in treatment failure, such as male sex, larger thyroid, severe hyperthyroidism, prior antithyroid medication use, and presence of atrial fibrillation. So hypothyroidism is inevitable and unpredictable. And so the goal of I-131 therapy in Graves' disease is to treat hyperthyroidism and not try to avoid hypothyroidism. I personally use a dose ranging from 10 to 20 millicuries. The minimal dose I will use in patients with very high uptake value is 10 millicuries, and depending on their uptake value and some of these other factors, I may go as high as 20 millicuries to treat patients with I-131 for Graves' disease. This is a good review article touching on various aspects of I-131 therapy for Graves' disease. Our next patient is a young female also who presented with a palpable thyroid nodule and underwent a ultrasound. First, ultrasound shows this heterogeneous nodule in the right lobe of the thyroid with peripheral and internal hyperemia on the color Doppler images, and the left lobe of the thyroid was normal. The next step in this patient's management was also I-123 uptake and scan, and this is an anterior image showing increased uptake in the right lobe nodule with a very high 19-hour uptake of 62.7%. The uptake in the rest of the right lobe and also in the left lobe of the thyroid is suppressed, and that is why we don't visualize it on this anterior image. And this patient is also a candidate for I-131 therapy. I would use a higher dose to treat this patient without worrying about hypothyroidism, because the suppressed gland will come back in terms of its function and make the patient euthyroid several weeks after treatment. Here on this slide, we have the ACR appropriateness criteria for initial imaging in patients who have thyrotoxicosis. And in the last two cases, we have seen how helpful is I-123 uptake and scan to differentiate between different causes of hyperthyroidism, which could range from Graves' disease, solitary toxic nodule, toxic multinodular goiter, or subacute thyroiditis. Thank you for watching.